Monique Ferro is going to be presenting Must DKA be treated with IV insulin infusion in the ICU, which is something that we always seem to do, I think. So we'll be enlightened.
Thank you, Dr. Fried. Again, I'm Monique Ferro Bezerra. I'm in the first year of the internal medicine categorical program. So let's talk about DKA. So the learning objectives today is bringing to the discussion the safety of treating mild and moderate DKA outside the ICU unit in a select group of patients, as well as show evidence in the selected group of patients have these patients treated with fast-acting insulin protocols, and show evidence of safe and effective alternative of the current standard of care treatment for DKA that would reduce significantly healthcare costs and save ICU beds. So why this is important? About 25 million of Americans, approximately 90% of our population, has diabetes. In 2017, diabetes was the 7th leading cause of death in the U.S. In the National Diabetes Statistic Report 2020, they released data from 2016, which showed that within 16 million ED presentations of patients with diabetes, about 200,000 was due to DKA. DKA account for 4 to 9% of all hospital discharges among patients with diagnosis of diabetes. In the U.S., one single episode of DKA can have an estimated cost of a little bit over $26,000 US. In the U.S., in a study released in 2004, which they evaluated the treatment with patients of the standard of care protocol of IV insulin compared with Lispro in an ICU setting, they were able to see that ICU was associated with 39% higher charge. The estimated annual cost can be more than $5 billion just for DKA. In the UK, where it seems they use less ICU beds to treat patients with DKA, the cost for the healthcare system is also lower. And of course, this is important because ICU is a scarce and costly resource. I think by this point of the year, all of us are able to know how the patients clinically present of DKA, but just to refresh our minds a little bit about the physiopathology, pathophysiology. So the patients with absolute insulin deficiency, in this case, we're mostly seeing patients with diabetes type 1, but also with relative insulin deficiency. It caused the increase of the counter-regulatory hormones, which mainly is the glucagon, but as well catecholamines, growth hormone, and cortisol that will produce the increase of gluconeogenic enzymes released in the liver with the increase of the gluconeogenesis and glucogenolysis. And of course, with the low glucose utilization, because the cells are starving, that will increase also the hypoglycemia. The proximal convoluted tubules are not able to absorb, filtrate all this insulin, will cause the osmotic diuresis, and then cause the electrolyte derangements and dehydrations that our patient presents. In the adipose tissue, this combination of severe insulin deficiency with the increase of counter-regulatory hormones activate hormone-sensitive lipase in the liver, causing the lipolysis, and then the increase of these free fat acids. There will be the excess will oxidize in the liver to acetoacetate and beta-hydroxybutyrate. That's what we measure, and the acetone will give those patients the characteristic breath, and that will be the cause of the ketoacidosis of our patients. So for the diagnosis of DKA, it's mainly based on a triad of hyperglycemia and metabolic onion gap metabolic acidosis, as well as a mental status. I would like to point out that for hypoglycemia, it's not in the criteria for severity. It's mainly based on the severity of the patient's acidosis and mental status. So the current state of care management of DKA, I'm not intent here to go for each part of the protocol, but just want to point out the mainstay of the treatment of the DKA is based on the fluid resuscitation and the potassium and other electrolytes replacement, and then of course insulin infusion. This algorithm here was from the UpToDate, and I just want to point out here that it's right there. Uncomplicated patients with DKA can be treated with subcutaneous route, right? So why we don't use that much? It's over there. Every service has their own protocol, but this is one of the protocols that I would like to point out from UpToDate. So this DKA equals to IV insulin infusion equals to ICU unit. In many institutions and for decades, DKA has been routinely treated in an ICU environment. And that's pretty much because those patients present with severe DKA, and also the frequent glucose checking and the titration of IV insulin, it quite require this level of care. However, we have several studies that show that mild and moderate DKA can be safely treated in the ED in medical wards, and subcutaneous insulin management could be the treatment of choice for those patients. They're not going to need ICU. So the American Diabetes Association Standards of Care in Diabetes in 2003 mentioned that there is no significant difference in outcome for intravenous human regular insulin versus subcutaneous rapid-acting analogs, combined, of course, with the other parts of the treatments. So individuals with uncomplicated DKA may sometimes be treated with subcutaneous insulin outside the ICU care. And this approach may be safer and more cost-effective than treatment these patients with IV insulin. I'm going to show you a little results from some meta-analysis and a few results, and then I would like to show you the very promising study that was done last year. But to start, I would like to show this meta-analysis that was released in 2016. After they do the triage of a lot of studies, they chose 5 randomized control trials that in total had 200 participants. 4 of these trials were done with insulin lispro, 1 of them with insulin aspart. And this study was based on patients with mild and moderate DKA. And this patient would follow for approximately 2 to 7 days of a hospital stay. And in the main results of this meta-analysis, they found no substantial difference in the time of resolution of DKA between the subcutaneous insulin and the IV regular insulin. In terms of hypoglycemia and length of hospital stay, the result was also comparable. They mentioned here children because one of these studies, which was in Brazil, it was only with the pediatric population. No deaths occurs in any of those studies. They didn't have enough data on the paper regarding morbidity and socioeconomic effects. Regarding the bias that they mentioned, it was not clear, and they couldn't evaluate a lot of the bias on all of these studies. However, they were able to say that for the outcome performance bias, there was a higher bias on these studies. On the conclusion, they say analysis suggests, based on low to very low quality of evidence, there is neither advantage nor disadvantage when you compare treating these patients mild to moderate DKA with either of the protocols. And they mention this as low to very low quality because the papers are not really clear, and a lot of the data, this type of studies, there's so many different data in terms of electrolytes, time of resolution, and all the demographic characteristics that was not well written in the papers that they thought that could have bias related, so they say low to very low quality of evidence. However, despite these limitations, they do conclude that treatment with subcutaneous rapid-acting insulin analogs appears to be a safer alternative to the use of IV insulin with these patients of mild to moderate DKA. And the conclusion of this meta-analysis was with accordance with all the meta-analysis released in 2009 and 2013. Another review study published in a British medical journal in 2019 showed the same conclusions of this meta-analysis that I just showed, saying that the subcutaneous insulin therapy is an alternative for patients with mild to moderate DKA. I'm not going to go in deep on these 4 studies, but I'm just going to show a little bit of what they did. So this author released in 2004 here in the United States. He did a study with 45 patients, and he did three protocols with IV insulin, and the insulin subcutaneous he did Q hourly and Q2 hours. And the reason these authors did this is because previously they had done a study with Q hourly and show that it was comparable to the IV insulin protocol. So they did this other one to show that the Q2 hours was also feasible and had similar results. So as you can see here, the patient lab characteristics were pretty similar in terms of severity of hypoglycemia and severity of acidosis. And as you can see in those graphs here, by the time of 24 hours, both groups, these 3 groups in this case, they had same results in terms of time of resolution of hypoglycemia, time of resolution of the acidosis. And it's all here, not in this graph, but also in the amount of insulin given. I'm going to mention what type of patient they exclude, and this is going to be for the other 3 studies. So patients with persistent hypertension, despite they given 1 liter of normal saline, patients with acute myocardial ischemia, end-stage renal and hepatic failure, and as Arcade mentioned, in pregnancy. And the primary outcomes, which was response of medical therapy, no statistical difference in length of hospital stay, duration of therapy until resolution of hypoglycemia, and also the amount of insulin used until resolution of the DKA. Hypoglycemia events, it was similar to all the groups, and no complications, no recurrence of ketoacidosis or mortality. The same author did another study in the same year, but this time with insulin lispro, and found similar results. We have an author released in 2006, this prospective randomized open trial in Turkey with 20 patients. This was with lispro, and as you can see in the graphs, the time of resolution of hypoglycemia and DKA are pretty similar. The exclusion criteria is also pretty similar, and the response to medical therapy as well. And the last study of these 4 was this study released in 2011, done in India with 50 patients, this time with also lispro insulin. The exclusion criteria is similar, the results are similar. I don't want to go further, show each one, but pretty much hypoglycemia, mortality not seen, and the time of resolution of a DKA and acidosis was similar. The conclusion, rapid-acting insulin and lispro is safe and effective alternative to intravenous regular insulin for this subset of patients, which was patients with mild moderate DKA. So now for this, the study that I would like to show you most was this one. Was actually the study that triggered today's presentation. Was a study released last year in the German network Open. Evaluation of outcomes following hospital-wide implementation of a subcutaneous insulin protocol for patients with diabetes ketoacidosis. So the objective was examine the outcome of patients with DKA treated with the subcutaneous insulin protocol compared to the IV insulin protocol, and at this time it was given to over longer periods than the previous study. And the main outcomes measure was different and difference evaluation. I'm going to explain in a little bit what different and differences mean in this study. of the need for intensive care unit, mortality, readmission, length of stay at the single intervention site. In this case, was the Northern California Kaiser Permanente Hospital, and I'm blanking now. It's gonna come to my mind in a little bit. San Jose with the insulin protocol. So the methods, we're gonna have 20 sites of the Northern California Kaiser Permanente hospitals that they're going to have the standard of care protocol of the IV insulin. All those patients are going to be treated in ICU care because none of the hospitals allow to have an insulin IV without being in ICU. So in the intervention side, in the period of a pre-implementation, the patient will be managed with the same protocol of IV insulin as the standard of care sites. And after the post-implementation, which started in 2016, this one site will start to implement the subcutaneous insulin protocol. And the patients that follow the criteria, they're over 18 years old, they had a Glasgow Coma Scale over 8, non-pregnant, do not exhibit non-DKA medical conditions, require ICU admission as septic shock, cardiogen shock, myocardial infarction, etc. One thing that it's important to point out, no study prior to this study ever did a subcutaneous insulin protocol in patients with severe DKA, and that's one of the things that caught our attention to bring this study today. So as long as there is not an exclusion criteria, those patients was also included in the protocol. And the severe DKA severity classification were determined on the basis of the ADA criteria I showed previously. I'm not going to go over to every detail of the protocol, but I would like to point out the insulin regimen that these authors did. So they did in 3 phases. The first phase, the patient will be treated in the ED. And the second phase, patients will be in a ward setting. And in the third phase, patients will be the discharge phase. So in the third phase, when the patients present in the ED, they will receive upfront glargine 0.3 units per kilo. And after that, they will receive 0.3 units per kilo every 4 hours until the resolution of hypoglycemia. In the second phase, those patients will already be on the ward. So they would reduce the dose of the insulin lispro to 0.2 Q4 hours if there is no resolution of the hypoglycemia yet. After the resolution of the hypoglycemia, they will continue the protocol. If the patient was already with insulin at home, they would just resume whatever dose the patient was receiving. If not, they would do what I mentioned here as an insulin sliding scale. And for patients with a glycemic DKA, they just consider like this patient will not receive this upfront doses. They just would go with a sliding scale protocol. The glucose monitoring initially was every 2 hours, but then will change for every 4 hours. So another thing that is different, this protocol that make this study also very important, it's all the other studies are Q1 hour, Q2 hours, and there's a lot of pushback because it's tough to do these protocols in the wards. So in this study, they did insulin Q4 hours, which it's more doable in the real world. Here, I would like to point out some lab characteristics of all the patients that were studied. So let's go back a little bit about the difference and the differences so we can understand what they did. So all the standard of care sites, they evaluated the data from the pre-implementation period and post-implementation, right? This study was done over years. So they evaluated the data from here and saw the difference from this period of time. So in the intervention side, they collected data pre-implementation and post-implementation. So if the protocol was effective, they're supposed to see the same difference found here, they should found here. So that's why they say they analyze the difference different on differences. Sometimes can be confusing, but that's how they analyze, and that's give a lot of power to this study as well, in my perspective. So point out some labs characteristics of these patients. You can see in terms of level of hypoglycemia, all patients had similar levels, initial level of glucose and severity of the anion gap, metabolic acidosis. You can see the bicarb levels were pretty similar as well. Here you can see the patients have similar kidney function, potassium levels, white blood count levels, and again, the arterial pH, it was pretty similar in all the groups. And again, point out that they also include the patient with severe DKA, and it was quite 46.7% of the sample that they have for the patients of this protocol was severe DKA. And that was also really surprising. So let's go to the numbers. I haven't mentioned yet. So the total of this study had about 8,000 patients. In the post-implementation on the intervention side, 122, which is a little bit over of all the other studies done before, combined with all the groups. So this study definitely evaluated more patients. Also would like to point out that the amount of insulin that those patients required and after 48 hours were similar in all the groups for the patients with IV and the patients in the intervention site post-implementation period. Also point out hypoglycemia events, which it seems there was a decrease in both sides post-implementation, so they don't differ much. And the time of resolution of the hyperglycemia, it was similar for the groups, and time of resolution of anion gap as well. So after the implementation, the 30-day readmission decrease, I'd like to point out here. At the intervention side, compare, you can see 21.1% to 9.8% post-implementation. In the standard of care, it didn't change much. It was pretty similar. They're pretty much unchanged in this other one. And the mortality, it was not significantly different in any of the groups. And using here the difference and difference regression, the adjusted rate, if you go over here, ratio for the ICU admission show a reduction to 57% on intensive care admission during this DKA, and as well a 50% decrease in these patients being readmitted in the hospital in 30 days. The hospital length of stay was not much difference. Let me go to the conclusion of the studies and then I tell my opinion. The authors found that the implementation of the subcutaneous insulin-driven protocol for treatment of DKA was associated with substantial change in practice, including a significantly decreased need for intensive care and reduced rates of readmission, with no increase of hypoglycemia or mortality. Results suggest that the subcutaneous insulin-driven protocol, including the selection of optimal patients, can be used effectively in treating DKA, although we do need more prospective studies. Regarding this, I always look these results of readmission in 30 days. I know there's a data that kind of show considerable decrease here. When I look at these studies, I think there's a high chance of performance bias for the 30 days readmission, because I do think the patients there under the protocol, they make sure that the patients have a good follow-up, right? So I always looked at with some critical analysis, but still, it was a very, in my opinion, important study and gave us a lot of data that was not studied before, and really good data. So those are my final considerations. In the select optimal patient, there is evidence that show efficacy and safety to manage patients with mild to moderate DKA with subcutaneous insulin outside the ICU unit. And after this study, maybe even possible having with severe DKA managed outside. I think we do need more studies, but it's there. These authors had the audacity to do that, and it may be even done. Of course, always an optimal patient. We have to kind of select the optimal patient. By managing DKA, patients in the step-down unit or wards, we can anticipate equivalent outcomes while also increasing the availability of ICU care for critical ill patients, which ICU, it's scarce even more after the pandemic. We know it is, right? And so why these protocols are over there, there is data, why we don't implement this. I think, first of all, lack of awareness. I think not everybody, physicians and all the healthcare providers know that this can be done safely. The fear of outcomes, since sometimes it's difficult to leave the standard of care of IV insulin infusion works so well, right? So we all fear when we change our practice. The shortage of wards nurse and pushback, and I don't want to say here this in a bad way, but we know it's always difficult to implement new protocols. There is some resistance. It's there. It's a reality. And I understand a pushback of a protocol, 1-2 hours. It can be quite overwhelming, but maybe the Q4 hours would work. And I also point out the need to buy in all stakeholders alongside before initial change in the standard of care, like representatives from the ED, critical care, endocrinology, nursing team. And to change the standard of care takes effort from hospital leadership to encourage all patients to develop and implement protocols that provide the highest benefit for everyone, our patients, the providers, and overall the healthcare systems. So these are my references. If someone wants to take a look, I'll be happy to share. And thank you very much. Questions?
Thank you. In that last study, you pointed out the readmission rate for the intervention hospital was, in my opinion, quite significantly lower.
Mm-hmm.
Did they talk about why that they thought it was, or do you remember?
I don't remember the mention that, but I know for a fact that all those patients had a follow-up with either endocrinologist, outpatient. That was the third phase of the study, right? The discharge. For at least for patients with diabetes type 1, they will have one endocrinologist consult in the hospital. They will have after the discharge in patients of they had diabetes type 2 and had a primary care. They will make sure they have a follow-up with the PCP. So like I said, and there is a higher chance for performance bias in my evaluation here, because when we are in a study, we make sure that our group of study have a good follow-up so we can have the data and analyze. So could be that. I don't see other reasons. Just want to point out something that I might have forgot. There was less rebound of patients with the subcutaneous insulin protocol when they were in the hospital.
That's what I was wondering. I have a different question. That's what I was wondering is, was it that the post-implementation group had longer in the hospital on sub-Q insulin to get kind of stabilized and to get the regimen sorted out?
So the time we have here, the time for the glucose, the resolution of hypoglycemia here, we can say this one in hours. It was 11.3, and this is post-implementation. In here is 10.7 hours. So I'd say it's pretty similar if you consider the standard deviation.
But what I'm wondering is, they were presumably then, if the length of stay was comparable, they were on subcutaneous insulin for longer in the hospital, and maybe they went out on a regimen that was already more likely to be successful, so they're less likely to be readmitted. I don't know if that makes any sense. Maybe.
Well, it's not clear on the paper, like how they did that after the resolution of the hypoglycemia.
Is there a slide with the length of stay?
It was on the next slide, I think.
The length of stay will be this one.
Yeah,
Overall.
overall length
That
of
over
stay.
hours.
It's actually, it was shorter.
It was comparable with the post-implementation. It's comparable with the post-implementation and the standard of care side. So I don't think it was that different. It was pretty similar.
My question was, so this is such a great Mythbusters, Monique. This is, I think, practice changing and really, really, really helpful to go through. The Q4-hour insulin is doable on the floor, but even in the most recent, the JAM article, this one, the glucose checks are still Q2.
Q2 initially.
So help the attendings in the room maybe understand. Is that something that the floor nurses are able to do for us routinely? Is that something that is labor intensive for them? Is that something that's feasible?
Well, I discussed this with Dr. Wilson because he's actually involved when there's like these protocols and everything. And he had looked studies before to try to see if subcutaneous insulin will be doable. Of course, we don't have a step-down unit. That would change the whole perspective. Step-down unit will solve the problem, right? But in the wards, Q1 hour, Q2 hours, there's a lot of pushback. And regarding the dose Q4 hours, but the checks, he will have to sit down with the professionals there and see. In this hospital that was implemented, actually, the author said there was a good acceptance from the ward's nurses. So, not say we're gonna do the same protocol. I just wanna maybe be possible eventually.
We could get around a lot of this with doing continuous glucose monitoring. Then you wouldn't have to do any blood sugars except at the very beginning and at the very end to make sure that the glucose monitor matched your lab approximation of the blood sugar.
Yeah.
So we could completely do away with that. But there's a tendency for physicians to hold on to tradition, even though if the tradition is based on nothing.
Last but not least, I guess we get to vote. So is it a myth? DKA can only safely be treated in the ICU using an IV insulin infusion. How many people think this is true? How many think it's plausible? How many think this is just busted? Looks pretty unanimous. All right. All right, we're busted.